Okay, wonderful. Hello, everyone. My name is Manar Alfaham. Thank you, Dr. Faris. Thank you, Prof. Mufti. I'm a PhD student at King's College London. My project is a joint project between King Faisal Specialist Hospital and King's College London. So first of all, briefly, AML is a heterogeneous disease. First of all, is my title. My project title is Comprehensive Profiling of Saudi acute myeloid leukemia patients using whole genome sequencing. So AML is a heterogeneous disease characterized by genetic and epigenetic changes in the hematopoietic stem cells that alter normal hematopoietic growth and differentiation, resulting in the accumulation of immature myeloid cells in the bone marrow. The reason why I have chosen this project, or why I have focused on the AML patient on the Saudi population, is because so far there is no comprehensive genomic profiling of Saudi patients, as far as I know, even from the Middle East. And because of high consanguineous marriages in Saudi Arabia, it's almost like 50%, which we might observe a high number of constitutional disorders that predispose to acute myeloid leukemia. Thank you. And also because of the general impression that patients from Saudi Arabia or in the Middle East are younger and have poor outcomes compared to the Caucasian population. So the aim of my study is to complete whole genome sequencing of around 250 AML samples to build up a population-specific database for genetic and for genetic variants associated with AML. The reason is just because we want to define the genomic characterization of a primary and relapsed AML to identify an anticipated targetable mutation. And finally, to carry out a comprehensive analysis of the cases of Saudi Arabia and white European patients' data sets. So this is the design of the study. Is first of all, I have collected clinical information for more than 500 AML samples, AML patients at King Faisal Specialist Hospital with help with Dr. Saeed Uthman. And then I choose some of these patients to conduct whole genome sequencing on them. The criteria that I have put here is that the patient should be aged like more than 18 years old, and also they should provide full consent and also diagnosed with acute myeloid leukemia. So in this project, I have two cohorts. The first one is the retrospective cohort, which is like I collected samples from the biobank at King Faisal, which are around 200. And then the other cohort is the prospective cohort. The aim was 15 newly diagnosed patients, but I was able only to get 27 patients. I collected from them saliva, buccal swab as a match normal because it was difficult to get the skin sample. And also I got from them some blood samples in case that we are going to conduct whole exome sequencing in future. So, and then I moved to the CGM to conduct the study. I extracted the DNA from the bone marrows and the buccal swabs, and then I built up the library and conducted the whole genome sequencing using Nova 6 machine with target coverage of 30 to 40 to 50x, and then I transferred the FASTQ files to King's College London to do the analysis. So briefly, I will not go in deeply on the steps here, but in general, I will tell you about the pipelines that we use to identify germline and somatic variants. For the germline variants, we have this what we did is that we called the variants using Starlink 2, Mutex 2, and then we annotate them using variant effect predictor, and then we try to get to divide the variants to two groups. The first one, which we call them like non-germline variants, if they are overlap with the germline variants that we have, germline genes that are associated with acute myeloid leukemia, and if they are pathogenic or likely pathogenic in ClinVar, and also if these variants have variant allele frequency more than 35%. And of course, if these variants have minor allele frequency in Saudi population less than 1%. And the other group is the novel variants, is when we didn't find them in the ClinVar, or they are not reported in ClinVar. At the same time, they are not reported in COSMIC. The COSMIC is the database for the somatic variants. So if they are not reported there as somatic, that's meaning they could be like germline variants if they have variant allele frequency more than 35%. What we found is, this is the heat map for the known and novel variant, germline variants. We found 106 known and novel germline variants were detected in 34% of the patient, which are like higher than what has been reported in the European population, which is like around 40%. To be like, to filter out this list of variants, I try to focus only on these variants that are have an association with the clinical information. So when I did that, I ended up with this list of variants of 15 patients, like 70% of patients have a mutation in 9 genes that are, so for this patient, even the variants are associated with clinical information or has been reported as germline in the literature. As you can see here, like in patient number 3519, as Prof. Mufti just discussed, patient with DDX41, he's a male, and also he has he's like meeting the criteria that this patient might have, this germline might be a germline. And also for patient with Fanconi anemia who has Fanconi mutation. Interestingly, what we found here is that for the last 3 patients, they are diagnosed with xerodermal pigmentosum, and then they developed acute myeloid leukemia. And because I know that these patients have germline mutation, I try to search, and also I try to find a germline mutation in their data. What I found is that in their novel list, there is a novel germline variants located in the XPC gene, that's arginine 286, that is detected in all these 3 patients. And
1 minute, Doctora.
Only 1 minute? Okay. So this is the novel germline variant that we found in our population. For the somatic variants, we have again filtered for novel and non-germline variants. I will go through them. So what we found is 2,400 somatic variants in total. It's like it seems like all the patients have somatic variants. But when I focus only on the non-somatic variants, we have like 22% of the patients have somatic variants. And these somatic variants, what I try to do is I try to compare what we found with the other population. The other population is the 3 databases that are published, Beat AML, TCGA, and Spencer. So I focus more on Spencer because they have conducted whole genome sequencing like what we did. For the other 2, they did whole exome sequencing. So when I did the comparison, I found like we have mutation in the same genes that are mutated in their database, but the frequencies are different. So I found that we have like 11 genes that are significantly different between Saudi and other population. The overall survival for all these genes are not, I couldn't find like a significant any significant association with poor survival, except for 4 genes, TP53, CHIK2, JAK2, KMT2A, and BCOL1, that are patient mutated with these genes have poor survival. So for the frequencies, hotspots, we also, this is a nice finding. What we found is that we have the same, it's almost the same frequency of hotspot detected in Saudi population compared to the other databases. And I focus actually on the cohesion complex, try to see if we, because we have high number of STAG2 and RAD21, so I try to see if we have, like, as reported in the literature, that these patients have poorer survival because their rules in the regulation of the separation of sister chromatid. What I found is that similar as other population is that we have exclusive pattern of mutations in all these genes in the Saudi population, like the other population, but the overall survival is not significant.
So we have to wrap up.
That's it.
If you can conclude.
Okay, so for the copy number variation, it's we found, like, some of the genes that we are expected to be altered. Some of the chromosome that we expected to alter in the acute myeloid leukemia are also altered in the Saudi populations. And one of the very nice, like, component in my study is the copy-neutral loss of heterozygosity. We found, like, a significant association between patient with normal karyotype and copy number loss of heterozygosity, who have, like, significant shorter survival than those with normal karyotype but without copy number loss of heterozygosity. These structural variants, interestingly, we have, like, identified like more structural variant identified by whole genome sequencing, but not by the conventional cytogenetics. And patient in Saudi population, as I mentioned at the beginning, they are younger, and also they seem to, for example, for patients with translocation 811, it's obvious here that they are younger than the other data sets. So in summary, that we uncovered the inherited mutation of the XPCG in 3 individuals affected by ectodermal pigmentosum, and also we observed similarity and in the commonly mutated genes compared to the published database. However, the mutation frequencies are different, and whole genome sequencing in our case improved diagnosis accuracy by detecting pathogenic variants in myeloid neoplasm genes, and previously undetected critical genetic alterations. And finally, whole genome sequencing identified translocations and copy number alterations detected by the cytogenetic analysis, plus we identified additional abnormalities in 55 patients. Finally, I would like to thank, of course, King Faisal Specialist Hospital, especially the Center of Genomic Medicine, Dr. Sultan Sderi, Salah Al-Baz, and Dr. Brian for helping me with this project. Many thanks also Dr. Nasser Bakshi for providing me with the samples, and thank you, Dr. Asman, for supporting me through all this process. He's my PI here in Saudi Arabia. And many thanks to my supervisor, Prof. Ghulam Mufti, and the bioinformatics group meeting led by the Dr. Mohammed Mehdi Karimi at King's College London. Thank you.